So I'm going to talk about targeted therapy. There are a lot of things to talk, but I will see how brief I can keep it. Greetings to you from Bangalore. So I will actually walk you through a patient who we have treated and talk about the evidence that we have. So this was a 60-year-old gentleman who was picked up to have liver lesions on a routine ultrasound, a routine health checkup, following which he was worked up and he was found to have growth in the rectosigmoid with liver metastasis. He had a CEA of over 1,000. So how do we manage him? So this is the algorithm that we have, that we group them into 4 groups, and based on the tumor burden, the patient characteristics, we decide what we do for these patients. And I think we have heard quite a bit about oligometastasis, liver resection, etc. So that's the algorithm there. So what is the evidence for chemotherapy and biologics that we have? For a long time, we've been using oxaliplatin-based chemotherapy, and that has shown a median overall survival of over 20 months. Similarly, irinotecan-based. And this is to show you that when we add bevacizumab to this chemotherapy, the overall survival has definitely increased. And this is data from a compilation of phase 3 studies, 8 studies actually. And so the evidence is that the survival benefit is consistent across all studies for adding bevacizumab. We now have these 3 biological agents that are there: bevacizumab, cetuximab, and panitumumab. And again, this slide shows you the evidence for each one of their use. We also are talking about sidedness of the disease and what happens. Of course, this is a retrospective analysis of 2 different studies showing you that there is a difference between left and right side, and that actually determines what biologic you will use, and we are well aware of that. Although this is a retrospective study, we are sure that this evidence continues, and that's because of the embryological origin of the 2 sides of the colon. And now we have evidence to talk about the molecular heterogeneity that is present in the sidedness. So with this, what is the impact of tumor characteristics on treatment decisions? This again is an algorithm essentially based on the RAS and RAF mutations. And we have newer markers coming in. So this patient actually came to us after he was treated with all these different chemotherapies, and he came to us for further management. He was evaluated for possible surgery at this point of time, and our surgeons took him up. He had a multiple metastatectomy in the liver, radical cholecystectomy, and RFA of the multiple liver lesions, some of which we already discussed earlier. And then we had to do his genomics at this point of time. His HER2 was negative, PDL1 was negative, KRAS mutation was wild type. So we continued his chemotherapy, although he had had several cycles of various chemotherapies going through. We realized that we could again recycle this because this was the best response he had to this combination. He also underwent transarterial chemoembolization. So I think we discussed this again, that we should use all possible modalities that we have to benefit our patient, and this was the local therapy that he got. But on follow-up, we found that there was a slight increase in his liver lesions, and he was continued on FOLFIRI and bevacizumab at this point of time. So why is it important for us to look up at genomics is from this pie chart that I've shown here. And I'm sure all of you will remember that the lung cancer is one that came out talking about the various genetic alterations, but we are now seeing it in colon as well, and that is ever increasing. So we look at BRAF because this is a prerequisite for the EGFR inhibitors response. And wild type BRAF, again, as shown here, works, the EGFR works best when the BRAF is wild type. So this is looking at the BRAF mutation, and this is one of the first studies called the ANCHOR, which combined encorafenib, cetuximab plus blinatumomab. And this is because when we target the BRAF pathway, we need to target the EGFR as well. Otherwise, there's going to be a rebound upregulation of the EGFR pathway, which leads to resistance. So this was the study design, and this is to show you the primary endpoint was overall survival, and this was met by the study. We also have another agent called ramucirumab, which targets the vascular endothelial growth factor, which is again what we were talking about as bevacizumab, if you remember the earlier slides I showed you. So this is a study called RAISE, which looked at using this ramucirumab with chemotherapy. The other target which is becoming important is HER2 as a biomarker for the colorectal cancers, and this is to show you the percentage of these HER2 mutations that are there in untreated, treated, and the various forms here. So these are some of the initial studies which showed that yes, anti-HER2 combinations in chemotherapy are useful, and today we have several of them that are available here: trastuzumab plus lepatinib, trastuzumab plus pertuzumab, trastuzumab deruxtecan, tucatinib plus trastuzumab. And the largest amount of data we have is for the trastuzumab deruxtecan, and this study is called Destiny CRC2. And this was a randomization in 2 arms of 2 different doses of deruxtecan. And this again is to show you the median overall survival for these patients is definitely appreciable. So the next target that was recognized was the KRAS 12C mutation. And the first study that looked at blocking this pathway was with a drug called adagrasib. And this was again combined with either cetuximab or by itself. The study was called Crystal 1. And this is the 2 graphs that are shown here. The first one is the waterfall plot, and the second one is the swimmer plot. Again, showing you that almost every patient did show response. So the KRAS, which for a long time had no target, for this specific mutations of G12C, we do have a drug now. So this was the other study called CodeBreak, which actually combined another molecule called sotorasib with panitumumab, again an EGFR blocker. And as you can see here, the tumor response and the tumor duration is shown in these 2 graphs. The next study was CodeBreak 300, which combined panitumumab with sotorasib. And the primary endpoint was the progression-free survival. And this is again showing you in a graph that this, in fact, is a positive study for the primary endpoint of PFS. This again is to show you that the data from real world, talking about these 2 different mutations, that the KRAS 12C and RAS mutation colorectal cancer patients, this real world data concludes that the 12C mutation is associated with numerically lower PFS and overall survival as compared to the RAS mutations. So this is again important for us to look at these genomic alterations to actually prognosticate and group these patients and tell them as to how they will behave. So the newer drug that's now coming targeting this, the KRAS, is called olomorasib. And again, this is very early data to show you that the responses are pretty good. Again, as you see here, this is combined with the anti-EGFR antagonist. So this was one of the first studies combining a TKI, that is lenvatinib, with pembrolizumab, because we always thought that checkpoint inhibitor should be used in a specific group, that is MMR deficient. And this was one of the studies which looked at those patients who were proficient, and this did show that there was some amount of response that happened. The other target that we are looking at is NTRK, and these 2 drugs that we have, larotrectinib and entrectinib. And again, this is to show you the responses that are there in this specific group of populations. So we have so many biomarkers today, the NTRK, KRAS, HER2, MMR, which Sendil already spoke to you about, BRAF V600, and the other BRAF mutations, and HER2. So this is going to be our response when we see so much data. So how do we go about is important for us. But this is a way forward that we can actually have specific group of patients who would be targeted by specific drugs. So back to our patient. This was almost a year after we saw him. He did show progression on the chemotherapy that we were giving. And as I mentioned, we had a discussion again, and we decided to continue with the same chemotherapy. But again, we had a biopsy from his liver lesion, and tried to see if there were any more genomic changes, but again, there was nothing specific. But his CEA was again going up. So this is a group of patients who would categorize as refractory colorectal. And what are the current available drugs? We have trifluoroperidine with tipracil, regorafenib, and fruquintinib. So these are the things that we have, and how we decide that is again by molecular guidance, and we look at whether we can re-challenge them with the drugs that we have had earlier, especially the anti-EGFR, or re-challenge them with oxaliplatin-based chemotherapy. And this is the data for you for this particular combination. The study is called Sunlight, and again showing you that there is an overall survival of using this group of drugs. The other one we have is regorafenib, which has been there for quite a long time, but it was usually used earlier on, but because of its side effects, it's gone away. But we still have this as a new, useful drug for us, and the data we have is from the study called Correct, which showed that there was a 23% reduction in the risk of death when this drug was used versus placebo. So this is another agent that blocks the VEGF pathway, fruquintinib, and this is again data to show you in the specific refractory group of patients. So just to coming back to our patient, this was the scan in March of 21. In October of 21, you can see the liver lesions increasing. And in December, we found that his ascites was increasing. He also had a peritoneal ventral hernia. So what do we do now? So I showed you the data with lenvatinib and pembrolizumab. So this patient was MMR non-deficient, but because of this data that came up at that point of time, we put him on that, and within 4 months, you can see that the liver lesions have disappeared. Why I took this patient of colorectal cancer and showed you was that this is again a slide from pretty long ago, just to show you that the median survival of these patients increasing with increasing lines of therapy that we give. Although this is an old slide, this is data from over 5,000 patients. And as you can see here, patients coming up to 4th line of therapy had a better survival. And that's why I took this patient to show you that with increasing number of drugs that we have today, we can definitely increase their survival. So this is the current way that we would like to treat. I don't think I'll go through this busy slide for you. One of the important things is that we've been involved in this guidelines publication. 2 of us from India were involved. This is the PAGA guidelines, which is Pan-Asia adaptation of the ESMO guidelines. So this is one thing that we do have today here. So this is the approach that we take to metastatic colorectal cancer. From 1950 till the last year, we have had chemotherapy backbone, but again, we have the newer drugs coming in. This is sort of a summary slide showing you the whole gamut of pathways that we have and several drugs that are there to block each one of these pathways. So for a long time, we just had chemotherapy, but we did show some increase in survival, but we needed more. That came with the biologicals. And now with the targeted therapies and immunotherapy that we have, we are looking at metastatic colorectal cancer patients surviving beyond 3 to 4 years. So with that, I will stop, and thank you very much.
Thank you, sir. It was wonderful, that whole gamut of molecules. I think most of the surgeons don't remember the names. They were just listening to. But just one question. What is your longest survival for any metastatic CRC?
I've had a patient going on for 6 years now.
6 years. So I had a patient with 8 years, and I have operated his liver 4 times.
Yeah.
So although Ms. Bora is giving your part, but still I think metastatic colorectal cancer, the way the molecules are evolving, they might become immortal.
In fact, I took this case because the importance of a multidisciplinary team approach, looking at local therapy for the liver, looking at surgery whenever feasible, I think it's a whole teamwork that's important.
Thank you, sir.